Hello and welcome. We're discussing whole genome sequencing at birth, implementing the Generation Study. The hashtag for the event is Generation Study, and this discussion has been made possible thanks to the kind support of Genomics England and the Newborn Genomes Programme. I'm Sarah Norcross, Director of PET, and I'm chairing the discussion. The topic under discussion is the Generation Study, which is an NHS-embedded research study, which is sequencing the whole genomes of 100,000 newborn babies. And this is to understand whether we can improve our ability to diagnose and treat genetic conditions. And the study involves babies born in various hospitals in England, and the results of the study will help inform future decisions about using whole genome sequencing to support newborn screening. Now, the idea of whole genome screening of newborns is not new. In fact, in the book Cracking the Genome by Kevin Davis, which was published back in 2002, Craig Venter was quoted as follows: "Within 10 years, every baby born in a hospital in this country will have its complete genome repertoire determined. Their parents will have it on a DVD disc or whatever the new media is at that time before they leave the hospital." Well, within 10 years, well, we know about those 10-year predictions that scientists make. They don't usually come to pass. But here we are in 2024, where in the UK, we have recently started whole genome sequencing of newborns. And I don't need to know much about the study. I don't even need to look it up to know that parents will not be leaving the hospital with a DVD. But there we go. So interestingly, in 2022, PET commissioned Ipsos to do some nationally representative survey work about the topics that we covered. And among the things that we asked was one about whole genome sequencing of newborns. And so they asked 2,233 people from a nationally representative sample this question, and I'll read it. Currently, the NHS offers blood spot screening, also known as the heel prick test, for all newborn babies. This genetic test screens for the presence of 9 different rare health conditions. It is possible to conduct a whole genome test for newborn babies that's aimed at screening for a larger number of rare conditions than the 9 that the current heel prick test screens for. This would include testing for rare conditions for which there is currently no treatment available. Would you support or oppose the NHS offering this whole genome test to all newborn babies in the UK? And as you can see from the donut over there, the majority of respondents, 53%, supported the idea of a whole genome test at birth, with only 10% opposed, 22% neither supporting nor opposing, and 13% answering don't know. So from this, it would seem that there's a decent amount of public support for whole genome sequencing at birth. And I should point out that our question is significantly different from what is actually happening in the Generation Study, as the rare conditions that they are looking for are, in fact, all actionable. So it'd be interesting to know if we went back and asked that question with that subtle difference, what the support would be and how it would change. But I think it's important, given that significant difference, that to mention a quotation which I heard just last week, actually, from a member of the charity Unique, which Sarah Wynne, their chief exec, used in a presentation. And this member of Unique, said, "Dumped with a diagnosis that no one knows about and left to get on with it. I'm finding my own way in the dark, advocating for my child. I'm glad they are screening babies, but it will only be useful if parents are supported and guiding and not just left like we've been." And so obviously it's good news that the conditions are all actionable, but also, I think people are going to want reassurance that that pathways of support are properly in place for people who get a diagnosis. Amanda is the clinical director at Genomics England, and she is responsible for leading the clinical delivery of the Generation study. She's a registered genetic counsellor with previous roles in the Bristol Regional Clinical Genetics Service and also Health Education England's Genomics Education Programme.
In the next 10 minutes, what I hope to do, kicking off the panel, is to give you an overview of the Generation study. Some of you attending today, this may be your first time hearing about it and you're curious to learn more, or you may be following it along with us over the last sort of 3+ years and interested to know on how things are going now. So I'll try and hopefully make sure that everyone feels a little bit up to date with where the study is, and hopefully then segue nicely into my fellow panelists who will be able to share much more of the on-the-ground experience about how they're finding the Generation study and other sort of considerations around that. So to dive in, I think it's really important to start first with the why. Why are we even considering this at all? Sarah, you started us off with a bit of an overview about what happens in newborn sequencing in the UK, where currently every baby is offered a blood spot test around 5 days of age to look for 9 rare and serious conditions. And this is a long-standing, very successful public health initiative. Over the last few years, there's been a number of movements both by the National Screening Committee about how we can consider the use of other technologies in screening, and also from patient organizations like Unique and like Genetic Alliance, where families' experiences of having a rare condition and that lengthy diagnostic odyssey, the length of time they've had to get to that diagnosis, sometimes having had another child at that point where they could have been able to find out if they had that condition or not and make sure that they could have testing and potentially treatment at birth, have really been advocating for expanding newborn screening to look for a wider range of conditions. So Owen, for example, was a participant in the 100,000 Genomes project. That was the project that really set off Genomics England as an organization. We are funded by the Department of Health and Social Care to support the NHS in delivering genome sequencing in the NHS and support research around genomics in health. Owen had his diagnosis through that project when he was 4 years old, and his parents really comment on if he had had that diagnosis sooner for a rare thyroid condition that could be supplemented with a thyroid hormone that could have been even more beneficial to his growth and development. Similarly, we see with Teddy and Nala's 2 siblings. Based on the time at which the younger sibling was diagnosed, she was able to access a new gene therapy that's recently been approved in the UK to treat metachromatic leukodystrophy, a very significant life-limiting neurodegenerative condition. But her elder sister had already had her symptoms too advanced to be able to receive that treatment. So again, really emphasizing the benefits of early detection and enablement of treatment. So a lot of these things have really brought together the need for us to be able to explore what genome sequencing could do in this context. We have previous experience through the 100,000 Genomes project and others where we've used genome sequencing for diagnostic purposes. It's now a clinical test in the NHS. But this is different. Using the technology in this way in newborns and as a population screening tool to detect potential conditions is new. And that brings additional complexities and challenges, which is why we feel it's really important to explore this through research and make sure we're really engaging with the public and the NHS patient organizations along with us to help us explore what this can potentially bring. So the purpose of the Generation research study, we have 3 broad interrelated aims, but we want to overall explore the potential of whole genome sequencing in newborns. The study seeks to sequence the genomes of around 100,000 newborn babies across England. It, like any other research study, has had Health Research Authority and ethics approval in order for us to run the study. And we're running this very much in partnership with the NHS, and it is a distinct research study to that NHS blood spot program that happens at day 5 that I mentioned. We know that genomic sequencing isn't the only way to increase access to expanding newborn screening. So this isn't just what the study is about. This is one route where we want to explore what genome sequencing can do in the newborn period. The first aim of this study is to see whether and how genome sequencing can be used to look for a larger number of rare conditions, and we're focusing on those that have an onset and intervention available in childhood. Parents consenting on behalf of their children would also be agreeing to their genome and health data de-identified and made accessible for wider research that would help us as part of AIM 2 to understand how that data might be useful for wider understanding of genomics and health, potentially to allow us to make new associations between gene changes and different conditions, help to develop new treatments and diagnostics that could support NHS patients for the future. And this is part of what we already do at Genomics England with consented data from participants who have had their genome sequenced for diagnostic purposes. The third and final aim is a much more exploratory aim at this stage, where we want to be able to continue to work with the public and our participants to explore the potential risks, benefits, and broader implications of storing a baby's genome over their lifetime. So at this stage, we're not necessarily committing to continually analyzing and asking new questions of the genome, but want to just understand what that could look like. What are the sort of implications? What are the questions that the public might have as that changes in the future? And crucially, as those newborn babies get older and gain more of their own autonomy to have involvement in decision-making about continuing in this study or not. One thing that's been really central to us since we've started this study is making sure that we're doing this with others. We think it's really important as something that is a population screening endeavor that we have a lot to learn from, that we do this with the public, with the NHS, with parents, understanding a wide range of views and how this might look if any element of this study were to be implemented in the future. So co-design has really been a core principle of how we've been running this study. And this sort of takes a number of different forms. We've worked very closely governance-wise with NHS England, delivering this in partnership with the NHS, and with the UK National Screening Committee, who provide advice to the government and the NHS about what conditions should be screened for, as well as the Department of Health and Social Care, who we are funded largely by. We've also, since we started designing the study 3 years ago, those earlier PET webinars that Sarah, you mentioned, that we took place to try and engage the public on various questions around this, has allowed us to help set up expert working groups to support how we design the study, covering a number of different areas from recruitment through to education and training and how to evaluate the study. We've also had a number of engagement initiatives focusing on particular areas. I've listed a few here, including how the public would consider the types of research that could happen safely on that baby's de-identified genome and health data, and the implications of storing the genome over a lifetime, which we're exploring currently through a public standing group. We've also had the benefit of carrying out a wide range of user research. Currently, that's happened to well over 100 parents and also with a range of different healthcare professionals, where we can help use their inputs to understand the materials we develop about the study, how the participant journey should look, and we hope to continue those activities as the study delivers. So where are we now? We've gone through that process of developing and designing the study, and I'm pleased to say that we have now started to run the study. So we're getting that experience of what implementation looks like. To date, the study is running across 13 hospital sites within 10 NHS trusts. We've had over 1,000 parents recruited, and because that recruitment can happen in pregnancy, waiting for those babies to be born for samples to be taken, that's why there is a smaller number of samples taken to date. But we're really seeing that recruitment and consent starting to ramp up, and that's given us a great opportunity to gain some experience about how that study is running. Crucially, this isn't a done deal that once the study is done, this will start happening in the NHS. The goal of our research is to help generate that evidence that can then be put to decision makers like the National Screening Committee and like the NHS to see if and whether something like this could be part of newborn screening in the future. We are running this, as I said, at a number of sites throughout England. We currently, as I said, are at about 13 hospitals, and that may increase to around 40 trusts or so. We really want to make sure that there's broad spread, so we're not just focusing on urban, very research-active hospitals, but looking at a variety of places that vary by birth volume, the diversity of the people and communities who access that hospital for antenatal care, maternity department and research department performance. We really want to sort of understand what the varying factors are to delivering this study in a range of settings. This is just a high-level slide to show you what the participant's journey looks like. And again, a lot of this has been informed by that co-design, engagement, and user research that we've done with parents and sites to help us make sure that we're conducting this study as safely as possible. Broadly, this involves parents hearing about the study during pregnancy, usually around midway through pregnancy, but that can vary depending on each site, and consenting to take part if they wish to before birth. And that is because the sample is taken very shortly after birth. So we want to make sure that parents have enough of an opportunity to hear about the study in a range of ways. A sample, usually a small sample of blood from the umbilical cord, is taken, and all of those samples are then sequenced. We would return a result to all participants. Every participant will receive a result. Most of them will not have one of the rare conditions that we're looking for in the study, but where they do, there would be much more careful follow-up steps in terms of management and care. There's a range of materials that we've developed, again, including user research with parents and staff, to help them make an informed decision about taking part in this study. We've tried to cater to what is largely a more digital audience and the audience of parents at this stage. And that includes everything from hearing about it through a poster or being introduced by a member of their study team or antenatal team, exploring information through a website or more detailed participant information sheet. We've also incorporated a range of ways to help make a calculated decision about whether this study is right for each parent, including understanding the uncertainties that may come with taking part in the study, that could come with results, and some of the potential risks that could come taking part in a long-term study that we think is important for them to consider. Now we're getting a lot of learning from our early sites, which is fantastic. This is what we really want to hear about and learn from so we can continue to make some changes as the study goes along. And I think some of the other panelists will speak more to this, but very broadly, what we're hearing is, as we probably would have expected, there's no one-size-fits-all approach to the recruitment journey. Each trust has a different geography, different patient population. So the process by which they're making those consent decisions and how those introductions are happening is naturally going to differ. So it's important for us to understand what each site needs. We are broadly hearing that a high proportion of parents who initially express interest do go on to want to consent. But again, how we're making sure that interest and awareness is spread across a wide range of parents is something we still need to learn how to best do. We know from sites that getting engagement, not just from senior enabling staff high at trust level, but also on the ground staff, is absolutely crucial to make this work. And as part of that, we've established communities of practice groups where we have members of trusts attend, which has been really helpful, not only for them to share challenges and experiences with us, but also with colleagues from other trusts so that they can learn and perhaps adapt some strategies that other trusts are using and learning. I know we're running short on time, so what I just quickly wanted to be able to share with you is a little bit about the results that we could return to parents. We are focusing very much on conditions that onset very early in childhood, within the first few years of life, and where there is some kind of intervention that could be done to improve outcomes in children. Again, many of these conditions are very rare, and that means that the information we have about them could be quite limited at this point. And that's again why it's important that we're conducting this study in a research setting so that we can continue to learn about what the outcomes for any babies diagnosed with any of these conditions is over an extended period of time. That's also really why it's important for us to have that genome and health data with consent, not just for wider research, but specifically for this study, so that we can track those babies that might be diagnosed with one of those conditions that meets these 4 key principles. And there are just over 200 of those conditions that we're looking for in this study. But it also allows us an opportunity to follow up on those conditions that we may not have diagnosed, but may be diagnosed elsewhere in those participants. So that includes what we might call false negatives in a screening context, where we might miss a case, but really want to understand by following up all of our participants why we may have missed those cases and what's happening to those babies in terms of their care as well. So as I mentioned, each participant will get a result. Those 200 rare conditions that we're testing for in this study, we expect that only 1% of participants, or around 1,000 of those 100,000 babies, will be diagnosed with one of those rare conditions. And where that's the case, we've worked very closely with our colleagues in the NHS to map out a high-level pathway for each of those conditions so that those families can be directed to the right pediatric specialist who would be responsible for arranging next steps in terms of confirmatory testing and appropriate further care. We've also worked with our study teams and colleagues in the Genomic Medicine Service to provide additional study-funded genetic counselling support and linking with patient organisations, because we know that's so crucial after a diagnosis is made or after receiving genetic information in general, to have supports on hand to be able to answer questions and think about those next steps in care. For the majority of babies who aren't suspected to have any of those conditions, we have, again, co-designed a carefully worded letter that will go back to parents that really tries to make this clear that this is research, this isn't replacing standard care. This doesn't mean a clean bill of health for the baby. Any questions about their family or medical history should still be followed up as normal, but also gives them an idea about what they could expect in the future as a study participant. The final point I want to make, bringing this back to research and us really wanting to make sure that we're generating evidence for future decision makers, including the public, to really assess whether this is something that we could and should do in the future, is evaluation. So we are working with an independent group based out of University College London, a combination of behavioral scientists, health economists, data scientists, that are conducting a range of research with sites and participants to help us understand what was the process of the study like, and what are the impacts and outcomes on the parents who took part and on the NHS staff who helped to deliver the study. We think that gathering that evidence along the way and at the end, in the medium, short, and longer term, is really important for us to provide that evidence to inform what a future world of genome sequencing in newborns might look like.
Next this evening, we have Phern Adams. Phern is the lead research midwife and project manager for the Generation study at Birmingham Women's Hospital. And Phern is a parent of a child with a rare genetic condition.
So I'm Phern. I'm the project lead for the Generation study at Birmingham Women's and Children's Hospital. And I'm going to today just discuss with you how we implemented the Generation study here at site and how it looks at Birmingham Women's. So I would like to discuss with you why this project is really important to me, anticipated problems at the offset really, onboarding and staff engagement, the participants pathway, and what our women and birthing people say, and currently how it looks at Birmingham Women's and Children's, and what the plan is next. So you've heard from Amanda already explaining the groundwork behind the Generation study. I myself can't really talk to you today without explaining why the study is important to me personally, but also to the families that we approach. This is my rare boy who received an initial diagnosis of variant of unknown significance from the 100,000 Genome Project. As more research became available, his condition now has a name. And as a health professional and experienced mom, I wasn't listened to with concerns about my child. Despite him having many complex medical needs, referrals were lost or not made. I have the knowledge to chase this up. Most families are not able to do this. My little one now, as you can see him in the middle there, he attends special needs school and has multiple health needs. We have a real chance to dramatically impact so many families' lives now it comes, but we need to learn from previous research and ensure that our families understand what they are consenting to. Apologies. So prior to launching, we understood that the study was going to be a big project. As an experienced research team, we anticipated some of the challenges. The study is using public funds, therefore Genomics England were very cautious with the funding models initially, which in turn then posed problems for staffing, and the study has a high sort of turnover of staff, and therefore regular requirements for training. My initial concerns about the study was that we would be giving very in-depth genomic-based conversations with our women, and there may be knowledge gaps hindering appropriate informed consent conversations. Prior to the Generation study, we have only ever received a maximum of 30% cord blood samples, and this is how we are screening these babies using cord blood. So only ever had 30% in previous studies, including when we have made it standard care. So there was big concerns about whether we would be able to receive those samples. And also then the backup would be potentially having a heel prick test. And obviously that then poses concerns about any drops in the newborn blood spot screening rate, as that would then have a dramatic detrimental effect and needed to be avoided at all costs. So my concern would be if we had less cord bloods, there would be more heel pricks. So at Birmingham Women's and Children's, we have a birth rate of 8,000 births a year, and ensuring each of the eligible women received the study information with a really small team was obviously going to be a challenge. And I knew it was, these mums were potentially not going to understand the any benefits for them. They weren't. It wasn't like the 100,000 Genome Project. It wasn't parents searching for answers that would have agreed to most things really to find those answers. This is potentially moms with low risk pregnancies that we're asking for quite a lot of a significant ask really as part of the study. So how were we going to do that? We sort of noticed really from the start, so we anticipated these concerns and realised that it was essential that we really focus on staff engagement prior to and during the launch of the study. So we established links with the communications team to support staff engagement. We laid on lunch and learn sessions. We had screensavers within the with all the computers within the trust. We set up a little Google page. So I guess that's our fake Google page there, you can see. So and that told all the staff about the generation study and had training links on there. And that also then all of our screensavers would link to that. And briefings with management, we managed to get it on the mandatory training, so all staff knew about study. And we have, all the staff are sick of hearing me talk about it on staff Facebook groups. And obviously we then have charity pages as well. So you can see there on the right hand side a post I put on the Delivery Suite Facebook group. And that was just really from when we first started at the very beginning, just thanking the staff for collecting the cord blood samples, because this was our biggest concern really at with the offset, and just offering staff little goodie bags of chocolates and pens as a thank you for doing that extra role of an already really stretched service. So what's the participant pathway here at Birmingham Women's? We offer a patient information leaflet to go in all the women's notes at booking. So everybody who books here has a really small pamphlet that they can look at just as really an overview of the study. We don't approach women at that point, but it's just there. And then at 16 weeks, we ask our community midwives, and that's from feedback from community midwives. They thought that was the most appropriate time to speak to parents. Really, they had that a little bit of extra time, and it tied in when they were having discussions around screening anyway. So at 16 weeks, we wanted the community midwives just to really have a quick overview about the study, just to point parents in the direction that the leaflet was in their booking packs. For any parents that expressed an interest, they could then refer on to us using our electronic systems if they wish to do so. Then at mid-trimester, so when women are attending their 20-week scan, their anomaly scan, they come to our radiology department, and we saw that as a good chance to be able to offer a bigger patient information sheet to parents, excuse me, sorry, because we know we've got a massive, because of our geography, we've got a massive amount of out of area women that will only come into hospital around 20 weeks. We know that's a good time with hopefully other birth partners being there as well. So we requested that gets handed to all of our women in whichever language they speak. So we have our 10 most common languages patient information sheet printed off, so those can be given to parents at that appointment. We have it as the recommended reading on our electronic note system, so that's Badgernet. And then we go and do a bit of an overview talk at our glucose tolerance test. So we stand at the front when women are there having not very nice tests really, but they're there for a couple of hours. So we use that as an opportunity to give parents an overview, well, moms an overview of the study at that point. We point them in the direction of the QR codes so they can self-refer. We make sure all of the patient information sheets are there with QR codes in other languages, so that they can, again, if anybody was missed at their scan appointment, hopefully they then receive that then. And we give all those printed off QR sheets to our interpreting teams as well. When women are attending for induction of labour, we approach women then. So we daily go to all of our inpatient areas, and we will speak to any woman that is an inpatient at Birmingham Women's and any of our induction women, just because in case they haven't had anything about the study within their pregnancy, so that they're not missing out on taking part in the study if they wish to do so. And women can self-refer to us at any point during the pregnancy. So I've worked in research for 10 years. I didn't think this would ever happen, and none of our other studies this has ever happened with, but I think this is a testament to this study. We receive referrals from women every single day, and that is it is when you look at our screening logs, it is a real mix of diversity really. But it's often professional women that are referring, but we do receive those referrals daily. So what's happening now at Birmingham Women? So we have a really mixed team working on the study with a really differing skill mix. But this is, I think, a really positive thing. We have staff from genetics, neonatal, gynae, and they all bring something different. But every one of our team is really, really passionate about this project. And I think that really helps with staff engagement and helps with our participants as well, wanting to take part. Unlike any other study, clinical staff have really been on board with this project. I think this is also aided by the support from management and engagement with team leads from the very beginning, really. Cord blood samples are being taken. This is my biggest amazement, really. After all of the studies only being at 30%, most of our cord blood samples are taken by the clinical staff. And I think that's a real testament to the teams here. I'm just amazed by them that this is happening. And this is, I think, because staff are really engaged with this study. And parents are asking for it. So moms are coming in labour and asking their midwife to take these samples at the time of birth. When they're in labour, they are remembering to say, please take my cord blood sample. And at times we have samples from moms that aren't in the study, and that's a conversation we have to have after they've had their baby, to say, unfortunately, those women can't be included if we haven't signed them up to the study beforehand and had sufficient time to consider the study and had all of the information. We have newborn blood spot screening. So that was our biggest concern, that it might impact the newborn blood spot screening. So far, I haven't had any feedback here at the Trust that is something that's happening here. We are really, really clear with all of the women that we speak to over and over again, really, during our conversations, that the differences between the newborn blood spot screening and the generation study. The only woman that I have been alerted to about this, there being a potential concern with a decline in the newborn blood spot screening, was actually, when we followed this up a little bit more, was a mom that had said that she had declined the newborn blood spot screening with her 3 other children because she doesn't have invasive tests with any of those children, and she had consented to the generation study. So and it was positive outcome, really, because we could have the conversations with her and explain, use the generation study as an opening point to then explain the importance of the newborn blood spot screening. And she then did consent to having conversations with the screening team to consider having the newborn blood spot screening. And again, self-referrals, the fact that we are receiving these self-referrals every day, that, yeah, as I've said previously, that is something that wouldn't happen with any other research study. So the feedback from our women has been extremely positive. We have a consent rate of about 50% if we include the women that we directly approach and also the self-referred women. We've recruited 380 participants into the study since we opened to recruitment on the 10th of June, making us the highest recruiting site. You can see on the screen the comments from our women. The question we get asked the most is whether delayed call timing is possible, and we have altered what we say as a direct result of this and tell women on the offset that we can still do delayed cord clamping, we can take any bloods we need to clinically, and then only take the generation study bloods when mum and baby have completely finished with it. And the other questions we get, really, I suppose, are about data security, which is we are able to answer and refer back to the patient information sheets, and most parents are happy with this. The reasons most commonly provided by women as a reason for not wishing to participate in the generation study is not wanting to be part of research and wishing to have standard care. However, most women do not provide a reason. It's also an interesting note that one of our team who wears a hijab has been told by a number of families that they do not wish to participate in the study due to religious reasons. I think it's important that we explore this, as I've never had a woman say this to me, and that's not surprising, really. However, we certainly need to explore this and look at ways to make our women feel more comfortable to express their beliefs and be able to tell us their reasons for not wanting to participate. So this leads me on to the more hard to reach groups, really. So you've heard now how a diagnosis was challenging for my family. Because we didn't get that part of the NHS, we got it part of the 100,000 Genome Project. And when we think of families where English is not their first language, or families with learning difficulties, the very families that would benefit the most from being part of this study, these are the women, unfortunately, that are not represented as much as they should be in this study, and this is essential that they are. So I've already begun to look at strategies to support this, such as helping with linked work and interpreter workshops, so they have a better understanding of benefits of research, as they're an advocate for their women. We include the interpreting team in the setup bespoke sessions prior to the study launch. It's not just a case of having leaflets in other languages, it's considering cultural beliefs and potentially a mistrust in research. I intend to continue this work. We are also going to work collaboratively with the GMSA and make this a priority target going forward. There is already plans for some of their team to go out to mosques in the upcoming weeks to liaise with religious leaders and look at how better we can engage with some of our communities. We need to work a little bit more on engagement with the neonatal team and how we can make sure we see how the babies that go to the unit we don't miss those cord blood samples, as all the samples that we do tend to miss are the babies, unfortunately, that are unwell at the time of birth or are born prematurely and go to the unit. So it's about trying to pick up those children a little bit better. Obviously, the study's going really well at the moment at Birmingham Women's, but it needs to grow. We need to be able to offer this to more women, and I think we need to do that through a lot more staff engagement. Just really wave one. There was always going to be wave one challenges, and communication is key, really, with other sites.
Following on from Phern, we have Dr. Chinthika Piyasena. have I got it right, who is consultant neonatologist at the Evelina London Neonatal Unit at St Thomas's Hospital. She is currently principal investigator for the Newborn Genomes Programme for Evelina London, and previously she was a principal investigator for the Next Generation Children's Project. She is a contributor to several books, including the Illustrated Textbook of Pediatrics and Rennie and Roberton's Textbook of Neonatology.
I will speak about the generation study in the context of advanced genomics that we already enjoy in neonatal care and what the addition of genomics to a comprehensive newborn screening package already means. And through the implementation of the generation study, I have spoken with many colleagues across the hospital, and I will be able to touch on their views on the impact of this study will have on children's services. So in neonatology, we really value genomics for diagnosis, and I could go on to say that we're really big consumers of it. Many genetic conditions present very early in life, and babies finding themselves admitted to a neonatal unit have a high chance of having a genetic condition. Testing can start, thanks to our maternity colleagues, during the antenatal period, or from the cord blood if a plan is made in advance. But we find rapid whole genome sequencing for sick babies particularly valuable, because every day on the neonatal unit without a diagnosis really counts. And with this advanced testing, we're able to receive a result in a matter of about 2 weeks from it being sent, and with a diagnosis found in the majority. This testing has been shown to shorten length of stay, be cost effective, be acceptable to parents and our colleagues. And actually, almost all parents who are offered this testing take it up. And it involves testing both parents as well as the child. And they generally accept also the option of their genomic data after the testing is complete to be entered into the National Genomic Research Library for future research. So we, in the neonatal unit over the last few decades, we've gone from doing just simple genetics for a few conditions to accessing advanced genomics for a much larger array of conditions, of almost 7,000, where a molecular basis has been established. So we have experienced a quantum leap in appreciating how wonderfully we're made to addressing that fearful nature by starting to deliver what is known as rapid, accurate medicine. And this is an example of a diagnostic odyssey that we have happily left behind. We had an example of a baby who was still in our neonatal unit at about 6 weeks of age. She was unwell, not thriving, and she had rapid whole genome sequencing. And she was tested at 6 weeks because the clinical features were still evolving and non-specific. But rapid sequencing, rapid testing allowed us to cut to the chase and start what is known as this baby's therapeutic odyssey. The condition this baby had is included in the generation study. And in the hypothetical scenario where this baby was screened at birth, we would have received a condition suspected report around 2 weeks of age, and found ourselves wondering whether it explained this baby's problem and had to contemplate further testing, or else really to understand whether there's something else that's actually going on. So early screening and testing has the potential to transform care for our babies, and it also provides the opportunity to uncover conditions that maybe we were not looking for. But in neonatal units, we see but a fraction of all babies born. Taking London as an example, care is delivered by networks, with each region having level 1, 2, or 3 units. Level 3 units look after the sickest and complex babies, such as the one that Phern's working at, with 4 of the London generation study hospitals having level 3 units. Each hospital sees more than 6,000 births a year, and generally, as a rule of thumb, 10% of all babies born need to spend some time in a neonatal unit. The generation study hospitals at the moment are aiming to recruit around 20% of all births. Yes, it's going really well in some of our departments, but actually still only expect a few babies both in the study and both needing neonatal care for those parameters to intersect. And this is because sometimes babies are admitted to the neonatal unit are born early. They're born prematurely, and they may not participate because there's been not enough time for the mother to give consent. We also look after twins who are currently not eligible to participate. So only when genomic screening is scaled up much more would the impact on very early life be realized. And of course, most babies are born well, most participating babies are born well, with conditions that are being tested presenting much later on. And there is already a very comprehensive screening package in place, such as looking for infection from day 1 to a hip scan at 6 weeks. The first few days is busy for babies, and if policymakers choose to include genomic screening as standard, doing so with cord blood as in the Generation study would not detract from the various established programs in place, particularly the newborn blood spot testing, which is crucial and must be honoured. So participating babies go home very quickly, and with that less than 1% chance of a condition suspected report being produced 2 weeks later. And here the paediatric specialist is responsible for relaying this research screening result. The specialist may not typically be used to delivering screening results and managing a period of uncertainty. Clinicians are concerned about turnaround times for validatory testing and being able to access genetic counselling. And this is where a member of staff responsible for fielding these results from Genomics England, locating the baby, and supporting the family and specialists navigate new workflows is absolutely key. And I'm very impressed by the amount of thought that has been put in place by Genomics England and NHS Genomics Services to assure this care. We have mapped out clinical referral pathways for each condition, and some usual ones being redefined and replaced with new clinical pathways. And we need to see how these are appropriate and how they're going as the study progresses. And regardless, all other aspects of routine and preventative care must go ahead. We have seen that some babies don't get their routine immunizations in context of some of the screening tests, but these understandings have to be implemented properly. And clinicians must retain an open mind about other disorders, regardless of condition suspected reports. Of course, the 99% with an initial normal result still needs to be considered. They will still be participating in long-term research studies with huge potential to generate new knowledge through the National Genomic Research Library. And I'm particularly curious about new diagnoses in babies who are unwell after birth, and we just don't know why. Children and families may present in clinic as they grow up, and they ask about their ongoing involvement when they attend. And paediatric specialists continue to ask about the possibility of future analysis to aid clinical care. So it's a brave new world, and the Generation study presents an opportunity. We need to work together to realise the benefits of genomics whilst minimising these risks. Neonatologists are generally supportive because it could transform care through early detection and treatment, paving the way for new discoveries. But we realise the enormous effort from our colleagues in midwifery and the paediatric specialists who take on these children. I thank all parents who've enrolled, and I think if I was a baby in this study, I would feel very privileged to be participating in what is cutting-edge science and being part of what is truly a landmark birth cohort.
And we will now move on to our next speaker, who's the final speaker this evening, Dr. Robert Lachmann. Robin. Oh, God, if I can't even pronounce Robin right, oh dearie me, things aren't going well now. Who's a consultant in inherited metabolic disease at the Charles Dent Metabolic Unit at the National Hospital for Neurology and Neurosurgery. He's chair of the scientific committee of the Recordati Rare Diseases Foundation, and he's co-author of the book Inherited Metabolic Disease in Adults, and a contributor to many more books, including Neurology, a Queen's Square textbook, Inborn Metabolic Diseases and Diagnosis and Treatment in Internal Medicine.
So I can't really talk about I look after children, adults with inherited metabolic diseases. We haven't had any positives yet from this study, so I can't talk about NHS implementation of that. So I'll concentrate on whether whole genome sequencing at birth is actually the way forward for newborn screening, or maybe not. So I think the first thing we have to realize about screening programs is that they're not all upside. All screening programs do harm. And that's mostly that screening programs will identify babies or people who don't have the condition you're screening for, false positives. Some do good as well. You may identify people who are actually going to benefit from treatment. And of those, some of them will actually be cost effective, because when you're doing a screening program with the whole population, the costs are really very large. The benefits may be quite small. So this comment that actually came from a review of breast screening applies equally well to all screening programs, including newborn screening. And that's why the National Screening Committee has this long list of criteria that they look into that have to be satisfied before they'll even consider launching a new screening program, including a newborn screening program. And so if we're going to get more screening, we have to be able to answer these questions. Now, there is a quite valid criticism made by Genetic Alliance, amongst others, that we don't screen for as many conditions on newborn screening in the UK as they do elsewhere in the world. So in Europe, so we screen for 9, soon to be 10 conditions, 7 of which are inherited metabolic diseases. But there are many European countries that screen for twice as many conditions as us. And in the United States, the basic panel recommended for newborn screening is 50 conditions. And there are many states in the US who actually screen for 100 different conditions or more. So certainly we are not looking for nearly as many potentially treatable conditions in babies as other countries are. And one of the aims that's been proposed for the Generation study is to provide at least part of a solution to this by providing a technology, whole genome sequencing, that could be used at scale to screen for a whole load of different conditions at the same time, about 200 in the case of the Generation study. And therefore, perhaps providing more information, more capability to screen for more things, more cost effectiveness, perhaps. And this comes from the observation, as has already been talked about in the 100 Genomes project and elsewhere, that if you use whole genome sequencing or indeed other new genetic technologies in patients with undiagnosed conditions, you can increase your rate of diagnosis. So this was 100,000 patients within the NHS who were suspected of having genetic diseases, but we hadn't been able to show clinical examination or by standard biochemical and radiological investigations what the diagnosis was. And when you gave those patients, offered those patients the chance to have a whole genome done, and you looked at those genomes in great detail and put them together with the clinical phenotype, about a quarter of the patients actually did then receive a genetic diagnosis, a condition they didn't know they had previously, and about a quarter of those in turn were able to benefit from some sort of treatment. So certainly we could increase our diagnostic yield in this group of patients with clinical disease who we hadn't been able to make a diagnosis in. But it isn't altogether simple. It requires an awful lot of effort to make even those 25% of diagnoses, and that's because of genetic variation. We're all very different. And so if you look at a group of people with a genetic condition or a suspected genetic condition, and you look at their genetics, you're going to see a lot of different variants and have to decide which one causes the condition. And this is a study from the States where they actually looked at 1.7 million people who'd had genetic testing done because they had an undiagnosed disease, they had a clinical phenotype. They hadn't, on the whole, had genomes. In fact, I'm not sure any of them had genomes. They'd had single genes or multi-gene panels, but on average, each of them had about 80 genes tested. And when they looked at the genetic results from that testing, then 40% of individuals had at least one variant in a gene that might have been responsible for their condition. And perhaps unsurprisingly, the more genes you tested, the more variants you discover. So if in the Generation study here, you're looking at about testing 200 genes, you're probably looking at finding a genetic variation in at least 5 to 10 of the genes that you're looking at. So 5 to 10 possibilities. Now you then look at those, and for a lot of conditions, for instance, that are recessive conditions where you have to have a mutation in both of your genes on each chromosome, then you can discount some of those because they don't have 2 mutations. And then you look again and you decide, is this mutation actually going to cause a significant change to the protein? Is it a pathogenic mutation, or do we know whether it's pathogenic or not? And you do that, and as in this study, in the end of the day, you can probably give 20% of patients a diagnosis, although more than twice that many actually had genetic changes. And that's in the context of a clinically affected population. What's important to remember is that when we're screening, and with the Generation study, we aren't looking at a population of patients. These aren't babies who've got anything wrong with them. This is a healthy population. And that adds an extra level of complexity and difficulty, because Any healthy individual will have multiple genetic variants. If you're looking at 20 genes, as with that population I showed you, 200 genes, you probably expect 5 to 10 of those to have significant variation within them. But when you don't have a phenotype, when you don't have something to actually say, this is the disease I'm looking for, how can you actually know what the significance of that genetic variation is? How can you interpret whether it's actually significant or not in a well baby? And this is a problem we already recognize in newborn screening programs from elsewhere in the world. So this is looking at newborn screening for a metabolic condition called adrenoleukodystrophy, caused by mutations in the ABCD1 gene. And in a proportion, it's an X-linked disease, so it affects males predominantly. And in a proportion of young boys with the condition, probably 30%, they will develop a rapidly progressive neurodegenerative disease in mid-childhood, which is fatal unless it's detected early, in which case it can be treated by a bone marrow transplant. So exactly the sort of condition we're talking about in the Generation study. And what this group did is they took two different genetic databases. First, they had a genetic database here, a clinical database. So these are mutations in the ABCD1 gene, which is responsible for this condition, that have been discovered in patients presenting with a clinical phenotype compatible with X-linked adrenoleukodystrophy. They didn't all have it, but they would have had a phenotype compatible with it and a diagnostic genetic test done. On this side, this is the genetic database established from newborn screening. So this is what happens if you screen a population of healthy babies. You look at the ABCD1 gene and you try and decide whether those mutations are actually going to be causing disease or not. And these are the results from the babies they called as positives. And the big thing to notice here is that we look at the pathogenic, the definitely pathogenic or the likely pathogenic mutations. Then in the disease, the patient database, that's accounting for about 70% of mutations, 70% of mutations that we already recognize as causing this disease. But in the screened population, there is half that many. Half that many babies are being called because they have definitely pathogenic mutations. And conversely, in the disease data set, the clinical data set, only 20% have variants of uncertain significance. There's 3 times as many, almost 2/3 of the babies in screening have been called because they have variants of unknown significance, which the researchers, the people looking at, think that might well cause a problem with this protein. And those babies are then being called as positives, and they're entering the screening, which in this case means MRAs every 6 months from birth up until the age of 12, and then every year, along with blood tests and things. But we don't actually know whether they're ever going to develop disease or not. So this is a lot of uncertain people who are being labeled as patients, created patients. And that's the risk of doing this sort of screening and perhaps overcalling. Can we make this better? Well, in ABCD1 genes with XALD, we can, because actually, if we use a biochemical test as our first-line screen rather than a genetic test, we can do much better. So this disease causes certain fats in the blood to be elevated. And if you measure some of those fats and actually look at patients, you can come up with diagnostic cutoffs that give you a subset of children who are much more likely to develop cerebral disease than if you use the genetic variants alone. So for this disease, we shouldn't be doing genetic screening. We should be doing biochemical screening. Genetic testing comes in here at tier 4 as a confirmatory diagnostic test. But genetic testing may have a role to play in newborn screening, therefore, but it's not always the first-line test. Now, the Generation study knows that. I'm not telling them anything that's new. And the way you get around that is to say, okay, but we're only going to call the definitely pathogenic or very likely pathogenic variants. So we're not going to call any of these VUSs. We're going to leave those well alone. That's sort of principle A. But that brings in all sorts of new problems of its own, particularly to do with the sensitivity and specificity of the testing then. If we look at screening for inherited metabolic diseases as a whole, and this is a study done in California where they screen for 48 different inherited metabolic diseases, so we do 7, they do 48. Nearly all of these, however, will probably be part of the Generation study. So of those 200 genes, we're probably looking at a large proportion of the genes we're screening for here. And they screen for them using biochemical tests. Metabolic diseases on the whole cause changes in different chemicals in the blood that you can pick up on blood spot testing. That's what the newborn blood tests is all about. So this group were able to get hold of all of the blood spots from any child in California who'd been diagnosed with one of those 48 inherited metabolic diseases between 2005 and 2013. So that was actually 674 individuals. So they had 674 blood spots, and they also got some who were screened false positive, who were then found not to have disease, which they used as controls. And they did whole exome sequencing in this case on those blood spots, and they looked at those 48 different genes, probably slightly more genes actually, because some diseases are caused by more than one gene that led to those diseases, and said, would we have diagnosed these babies if we'd used a genetic screen as our first-line screen? And they went through and they looked at the different mutations, and first there were those definitely clinically significant mutations, but then they looked in a bit more detail at things that were rare mutations, VUSs, and decided whether they thought they'd affect the protein or given that they knew the baby had the disease. And by the time they got through it, they were diagnosing about 571, so missing about 100 of those babies who'd been diagnosed by the definitive biochemical test. And that meant they had an overall sensitivity of about 88% compared to 99% on biochemical testing, and a specificity that's also considerably less. The difference between 98.4% and 99.8% doesn't sound very much, but when you're screening millions of babies over a 13-year period or 8-year period in California, it's a lot of false positives. And that was bringing in all these VUSs. If they decided only to use the definite pathogenic mutations, they'd have had their sensitivity down to about 50%. So yes, you're diagnosing 50% of the babies, but you're also missing 50% of the babies. So 50% of the babies would have had the disease and never been picked up by a genetic screen. So if you only call pathogenic variants, that has a real effect on your ability to actually diagnose all the children with that disease. So for many, probably most of the conditions being screened for in the generation study, genetics would not normally be your first-line test of choice. In fact, all of those conditions, as Amanda said, have been chosen because there is a second diagnostic test you can do. And normally, if you were starting from scratch, that second diagnostic test is probably the one you'd do first. WGS as a tool for newborn screening lacks sensitivity and specificity, particularly if you're going to restrict yourself to calling definitely pathogenic mutations. And it's far too slow. We haven't really touched on this, but for a lot of these inherited metabolic diseases, you really need a result back within the first week or two of life, or that baby is going to get unwell and present clinically. Now, there is an ambition to be able to turn these genomes around within 2 weeks, but doing that on a population basis would use an enormous amount of resource. At the moment, on the patient-facing website, it says you're going to get your results within a few months. And I'd have to say, in a research context, that may be fine, but for the individual baby, that's far too late to be getting the result on the whole. So what is the generation study actually for? Well, remember, it's not just about newborn screening. This study has 2 different arms. The population genomics arm is actually the one that every single baby will be contributing to. So every baby is donating its genome to the National Genomic Library, where it will be linked up with its lifetime health records, giving the potential to do really important research on population genomics, on the interaction between genetic variation in multiple genes and population health outcomes. But that research is all being done by other researchers. That isn't part of this study. It's establishing the library that's part of this study. The other arm is the newborn screening. We've already said that only a relatively few babies will get a result for a newborn screening. They're expecting somewhere between 5,000 and 1,000 screen-positive babies. And actually, they're only reckoning that between 200 and 400 of those will actually have a diagnosis made that requires care or surveillance within the NHS. So a very, very small proportion. And actually, to make those diagnoses, we're looking at 200 genes, but it still only needs you to look at 0.02% of the genome as a whole. So the vast majority of the data that's being collected in the genome isn't actually being used for the newborn screening part of this test. And if you were doing newborn screening, you probably wouldn't use a genome, you'd use a selected panel, which would allow you to turn around your results a lot quicker. So what will the generation study tell us? Well, it can tell us if we can get consent to do a genome at birth. Getting consent to do genomes has historically been quite difficult. But if you link it to the offer of newborn screening, maybe you can get more parents to consent. And it'll certainly allow the National Genomics Research Library to have a lot more genomes in it and a lot more power in the future to do meaningful population genomics research. But what it can't tell us is how we should be doing newborn screening for any of those 200 conditions that are there, because we're only being offered the one test, the actual rather insensitive genomic test. It's not going to tell us anything about the epidemiology, pathobiology, or clinical features of any of the conditions, because the numbers of patients being detected are just simply far too small. And actually, they're then being handed over to the NHS. We don't know how that's going to work yet, because we haven't actually had any positive babies detected. But maybe if we came back to this in a year's time, we'd be able to look at how the NHS pathways are dealing with that. And because it's not giving us any of that important epidemiological, pathobiological, clinical information, It's not going to help the National Screening Committee in making those decisions about should we be screening for condition X. That's going to need a lot more information that's going to have to continue to come from different sources. So will Generation Study advance the case for expanding newborn screening? Well, it certainly has done politically already. We're having this meeting. There's been a lot of attention in the press. The National Screening Committee has actually been reconstituted and reorganized. So that's a big tick. But scientifically, are we actually going to be able to answer any extra questions? This is a study about a technique of doing a genome screen on a really relatively small number of babies when it comes to diagnosing rare diseases in the general population. And it's quite unlikely, in my view, that we're actually going to get the information we need in order to take forward newborn screening for a significant number of extra conditions in the NHS.
I'm going to start with some questions around some sort of practical questions, actually, which is how much cord blood in millimeters is required for this study? I don't know who knows the answer to that one, but that's something that's taken somebody's imagination. Does Amanda or Phern, do you want to go for that one, Amanda?
I think Phern's good to answer that. Had more on-hand experience.
They go on, Phern. Is it a bucket full or a tiny bit?
No, we asked for the midwives to take 3 mils of cord blood, and actually they've been getting over that amount. So the cord blood samples are absolutely fine. It's a really small amount of blood.
And then there are a sort of series of questions around getting access to a copy of the genome. So one person's asked, will participants get access to a copy of their genome sequence they can refer to later? They've not asked for it on a DVD, but instead stored on, will it be stored on a server that they can access securely? Someone else has asked whether patients can legally, sort of demand a copy of their child's genome. So perhaps Amanda, if you want to start on that one.
Yes, sure. So in general, we don't automatically provide a copy of the whole genome to participants. And sometimes that can be a misconception, which is something we hopefully try to clarify in our study materials, that when we're giving a result, we're being very specific about almost like a report that is telling us about specific areas of the genome that were looked at. We don't own that person's genetic sequence as Genomics England. That is theirs to own. They are entrusting their data or their baby's genome data safely with us. And there is a process by which individuals can request theirs or their child's raw data. That happens in participants in the 100,000 Genomes projects very rarely. It involves a multi-step process of requesting this through our data protection team, speaking to a member of our team about the implications of having that raw data and what some of the limitations of having all of that is. And that individual would need to provide the storage for kind of holding that genome themselves, if that is what they wanted, because each whole genome file is actually quite large, sort of several gigabytes in size. So there are often a few requests that we get, and when people actually realize what they mean by the whole genome, they don't necessarily want the raw file. They just maybe want to understand more about how we interpreted it and what kind of information we might have found or not looked for.
Right. Okay, so I'm going to move on to another practical question, which is, my apologies if I missed this, but did I hear correctly that twins are not eligible for the Generation study? If so, can you help me understand why? So are twins eligible, Amanda?
They aren't at the moment, no, and that really is largely due to just our the complexity of our systems at the moment, where we consent sort of mums just before birth, and then being able to have a record of that participant and the baby that comes afterwards. So currently we aren't able to sort of manage a participant and then 2 babies with samples that come afterwards. So there isn't anything sort of for or against having twins that is any factor in that decision. It's just that at the moment, that's something that we aren't in our systems able to do. That could change.
How long do you think that will take to come on board?
I think it's difficult for us to say, because at the moment we're still quite in relatively early stages of mobilizing the study and making sure that our systems can work really well at scale. So I think it's quite difficult to give a timeline on, but in general, otherwise, and I think maybe there were also some related questions about eligibility criteria. The criteria are quite broad. It doesn't necessitate needing to have a known history of a genetic condition or family history of a genetic condition. So the criteria are quite broad, but the few exclusion criteria we have might be due to where parents might not have parental responsibility, or where we just have kind of technical issues with being able to include some of those participants like twins at this time.
Yes, I think that was a question from Kathy Herbrand. I'm just trying to scroll into my head. Yeah, she asked, is the screening available to all new parents? So we rule out twins. If not, what criteria are used for selection? So is there anything else that we need to add to answer that, or have we covered that now, Amanda?
I don't know if Phern would like to add anything about her experience dealing with that at the coalface.
Yeah, they need to be birthing at a hospital that's participating for the practicalities of being able to get the sample. They need to be registered with a GP in England. So we have a fetal medicine unit here where families might come from Wales. So that's why that's quite relevant to our hospital here. And yeah, some of the things that Amanda's already discussed there, really. They need to be over 16. They need to be, they need to have parental responsibility and have an NHS number.
Great. Thanks for that. And then a related question, because they've also asked about twins, but we'll forget about that bit. For Amanda from Veronica Odinsova. And she asked, do you plan to collect DNA methylation data and screen for imprinting disorders?
That's not something we're doing at the moment. No, that would require either a different type of sample or different way of processing those samples. Again, that may be possible in theory for us to do that in future, but that's not something that we are currently planning, and therefore, meaning that we wouldn't necessarily be able to detect imprinting type disorders.
Right. Okay. So there's a broad question, really, from us asking, do you understand why there is mistrust with research from other cultures or ethnic minorities? And I don't know who would like to tackle this first. Do you want to sort of talk about this first, Amanda? Because you must have come across this, rubbed up against this with the 100,000 Genomes Project as well.
Sure, yeah. It's a very good question to be discussing. Do we understand? I don't think we can say that we fully understand, but I think we are certainly seeking to understand, and that's what I hope we've done a lot of so far and can continue to do. So we do know in general that there is that some people have historically been excluded from research for a variety of different reasons, and we see that in a number of different communities. We know from just a genomic data point of view that our available genomic data sets largely or disproportionately consist of individuals of Northern European ancestry. That only gives us a very ancestry-specific lens. It doesn't tell us about lots of other factors, but it certainly tells us that there's a limitation there. And we know that in the past, genetics has been used in lots of different ways that fortunately we have much better ethics and governance procedures in place to avoid a lot of those harms that have previously happened from happening again. I think some of the ways that we're hoping to tackle that, I mentioned in my talk earlier about really kind of being committed to co-design with parents and members of the public, has been that from the start, we've really tried to understand a range of public views that may feel supportive or very not supportive about the idea of this, and understand why that is, trying to explore how we can better understand the opportunities to introduce genomics and genetics and research into communities who maybe haven't had great experiences with that in the past, and maybe would like to be able to participate, but really want to be able to be met where they're at and understand what their concerns are. And part of what we're doing with sites, and Phern might want to come in here, or Chinthika, is helping to understand some of the specific needs in the communities that use their hospital, and therefore what different sort of recruitment strategies or engagement or awareness work might be well placed, so that some of those communities might feel like, and making sure that we have as much as possible equitable access to participation in the study. So I don't know if Phern, you'd want to speak to some of what that local experience maybe has been like for you.
We have, as I said when I was speaking, we've done a lot of engagement work with our interpreting and link workers team, really, and listen to their feedback, because they are the women's advocate. They are speaking on behalf of those women. And I think often with previous studies, we've been met by a little bit of a wall, really, because we can't have that initial conversation with women to let them know what we want to discuss with them, to see if they want to listen to us, or they're happy to consent to a conversation with us, let alone consent to a study. So I think that's been key here, really, just having those sessions with the interpreting team, just so that they can understand their sort of myths around research initially. So we did things like monkey polls to see their thoughts on research, if they would take part in research, if they knew any studies, what sort of things they've been part of. And we discussed different types of studies. And I think lots of the team weren't aware of the type of research that we do and we offer here. Simple things that women have better 25% more likely to have better outcomes by taking part in research. And there's really a lot of engagement work has gone underway, and then those women are then speaking to our potential participants and saying, would you like to take part in this study, or would you be happy to have a conversation with our research midwife? So that's a lot of what we're doing here.
Okay, Robin, did you want to come in?
I was going to say, it's also worth pointing out that it's a vicious cycle for ethnic minorities, in that because they're not properly represented in the data sets, it's much more difficult to interpret any genetic variation you find. We don't have so not being there means that actually you're also going to get much less reliable results.
So we've got a question, Robin, for you from Vanessa Burns, who says large-scale multiplexed assays of variant effect MAVs are becoming increasingly common. These screens test the effect of thousands of variants, often every possible SNP, for example, in disease-causing genes, and produce variant effect maps that accurately resolve VUS, hence facilitating genetic diagnoses. Do you expect your ranking of the utility of genomic sequencing to shift as these variant effect maps become available? Please don't ask me to repeat that question. It's quite long.
I think possibly, but they're not going to stop. They're not going to make the biochemical tests any less accurate than they are already. And for a lot of the things we're dealing with, the biochemical tests are really very, very accurate. So you may get genetic testing becoming closer to biochemical testing, and the fact that you can multiplex it is an economy of scale. But I'm not sure that's necessarily going to mean that if you were looking on an individual disease basis, you'd necessarily still be going for the genetic test. And you also have to deal with the fact that for a number of rare diseases, lots of families have their own unique mutations. So yes, maybe being able to predict the effect will be helpful, but I'm not sure it's necessarily going to take it up above when we have a very good biochemical test already, and which tells us more about the actual degree of the disease than the genetic test does as well. And we know there's lots of genotype-phenotype correlation that is better predicted by biochemical testing, as it is in XALD, than it is by genetic testing.
Okay, one for Amanda and Phern, I think. Do parents need to consent? Do both parents need to consent, to the study to participate?
Yes.
Yes.
Not in person, but we, as part of the consent process, we discuss with, ideally we'd like to have both parents there, but we discuss the study with mom, and we ask the question and pose it really that if they are in contact with dad or the father of the baby, then they need to also consent to the study. So some of our moms that aren't necessarily in contact with the father of the baby, or they don't know who the father of the baby is, that's not an exclusion to the study. But if they are in contact with them, whether they're together or not, both parents need to be happy with the study because of the potential implications for wider family and future pregnancies. Really, it's and women, all of our women are aware of that.
Great, thanks for that. And then probably one for you, Amanda, from Graham Wood. Very simply wants to know how he can find out about recruiting centres.
The best way is to go to the study participant website. That's just www.generationstudy.co.uk. And on that, that will enable participants to understand if they're delivering at a hospital that is live for the study. And we keep that updated as sites go live. So that will allow you to see a list of which sites are open.
Okay, so we have one now from an anonymous attendee. He says, last week it emerged that data from 500,000 UK patients held in another national database, UK Biobank, has been shared with a eugenics organisation advocating nefarious theories that intelligence is based on race. Who will get access to data obtained from the Generations study? I think that's one for you, Amanda.
Yes, sure. This is I've seen the article come out about that and a couple of others. So until recently, the UK Biobank had a very different method of data access than the process that we have at Genomics England and that other research programs might use, where researchers can broadly take some of that data away with them to conduct those analyses. Our process is and the UK Biobanks now is very different. The process we've always had since we set up the National Genomic Research Library for the 100,000 Genomes Project is very much on a kind of lending library type basis. So researchers can look at the data and do their analyses within the environment that we host, but can't take that data away with them. There's a number of sort of governance structures in place in terms of who can access the data, in terms of researchers having to they could be from academia, from hospitals, from charities, they could be from healthcare companies, but they all have to undergo the same scrutiny and propose the research that they'd be doing in that environment, being within our acceptable uses policy relating to genetics and health. The committees that govern that access include participants whose data is in that library, because we think it's very important that those people whose data is entrusted to us can help make the decisions that are important to them. And also, when any of that data that researchers do is taken away, that summary level data is also scrutinized before that is released. So that's what we call our airlock policy and our airlock committee, so that we can also scrutinize any of the summary level analyzed data before that goes away. So we think that's provided us with a much more robust governance mechanism to make sure that we're really only using that data for acceptable uses in genomics and health.
Do any of the panelists want to come in on that, Robin?
Yeah, and there was another article about another company using it to select fetuses on the basis of intelligence as well, which isn't ideal.
Yeah.
The worry here is the reputational risk for the whole newborn screening program. So if Daily Mail gets hold of this and gets hold of the Generations project and puts newborn screening for diseases in genomes, as in measles, people stop having the blood spot test. And we must do everything we can to make sure that doesn't happen.
Yeah, good point. So we have a question now for Chinthika from Frances Flinter. She says, surely genetic testing on a sick neonate who urgently needs a diagnosis is completely different from testing apparently healthy neonates who have no symptoms. It would be much easier to interpret the significance of unusual variants in the genes. What would you, it's not so much a question as a comment, but do you want to come back on that?
Thank you, Francis, for your question. Yes, absolutely. I wanted to illustrate the difference between using genomics for diagnosis in our sick newborns versus screening in the well newborns. The babies who are going to be part of the generation study and be part of the neonatal unit are going to be very, very few. So the vast majority of babies who are going to be in the generation study are going to be well, asymptomatic, and would have the challenges of understanding what the report means for them.
And I think that leads on to, unless anyone else wants to come in on that, I'm not seeing any. Then David Curtis says, you were talking about making diagnoses, but an initially positive genetic test is not a diagnosis, is it? It's probably a false positive. It's expected that false positives will far outweigh the genuine cases of disease, let alone actionable ones. So who wants to come in on that one first? Robin?
So I think false positives are part of any screening program. They're one of the disbenefits of screening. And that's why sensitivity and specificity are extremely important. All screening programs involve at least second-tier testing. Well, they involve getting a baby in and repeating your first-tier test to start off with on blood, and then second-tier testing. And there will always be a number of babies, and often a majority of babies, who are given false positive results and then can be reassured. But there's a lot of concern about that because you medicalize that baby from a very early stage. So the question is whether we're more likely to be seeing that with a genetic and certainly a genomic screen than we are with some of the other screens that are available. And yes, I mean, the point I was trying to illustrate is that for a number of the diseases, we do have more specific and sensitive tests. They may need to be done individually rather than being able to look for 200 different conditions at the same time, but that will avoid some of those issues. But in any screening program, you need confirmation, and there will always be false positives and false negatives.
Yeah, Robin's right. Our goal is to be able to make earlier diagnosis, but the initial results that come from the study really highlight that a condition is suspected and that further testing needs to be done. That's also something that we hope, and Phern will maybe have much more live experience with this, that is a key concept that parents also appreciate when they're signing up to the study. And as Robin says, we expect to have some false positives and negatives like every screening program. Our modeling to date, although again, we're not in the live phase of returning results, this is based on modeling of genomic data, suggests that the majority of results will be true positives, not false positives. But this is something we'll need to continue to monitor. The other thing we have to be mindful of is it's not necessarily always a binary, a true positive or a false positive. With even a true positive result, there come uncertainties with getting that information and being able to convey information to that family about exactly what the next steps are going to look like in terms of any interventions, in terms of the severity or onset of other types of symptoms. So that's also a key area of uncertainty that we want to make sure parents appreciate before they do the test, and where we hope that the support that we build in those results pathways can also help families to manage that when they have questions.
It's also worth pointing out that if you restrict yourself to calling certain variants that you know are associated with disease, your risk is false negatives. You're missing them, yes. And you almost get to the point where actually you're saying we're not providing a screening program for this disease. We are calling certain high frequency mutations, and there's precedent for that in the Ashkenazi Jewish population, where there are certain mutations that are very common and they can call, but you won't necessarily find the sporadic mutations that come up. But when does a screening program stop? Or what percentage of false negatives do you stop having a screening program and start having a specific genetic variant diagnosis program, high-risk diagnosis program?
I think hopefully that's something we want to really be able to explore. The clinical scientists that we have providing that kind of manual review over any variants that are prioritized in cases we see, who have that real expertise in doing that. That's been really helpful because it's understanding how many databases they can draw on to understand the sort of pathogenicity of those variants. We do want to be cautious because we want to limit false positives whilst recognizing that that might mean more false negatives. So that's one of the key evaluation outcomes that we need to be able to explore as we start returning results, is really understanding what that sensitivity and specificity will be. We can do that modeling, but also can't prejudge the conclusion of that, I think, until we can see how that works in the study.
And you can do that quite accurately for the conditions we already screened for. Not so easy for the conditions that we're not screening for yet, because you don't have any, you don't know about your falses because you never see them.
There are ways that we are. Yeah, there are ways that we are sort of, that is being detected within the study as well, and it is about really close relationships with the newborn screening teams, and that is data that is being analysed for parents that do participate in the newborn blood spot screening. With regard to what we tell parents, they're very, we're very clear on the fact that it's a screening test, and it needs to be confirmed with diagnostic testing. So all of our families, when they do sign up to the study, they're told about there are uncertainties and there is potentially false negatives and false positives. And it also, as per Amanda's slides, in the patient information sheets and website, it's very clear in all the information that we give to families written down as well.
Okay, so I'm going to go to some questions now about consent. And so it's an anonymous one. Probably might be best if you take these in the first instance, Phern, and then others might want to chip in. If you're approaching women at multiple times in the pathway to consent, will parents feel possibly pressured or coerced because they've been asked multiple times? What do you think about that? Is that something that's sort of the conversation that your team are having with people?
No, we don't approach parents multiple times. So when I was, I obviously wasn't very clear in my presentation. Apologies. So we introduced the study with regard to just putting an information sheet in their notes, and we don't approach them multiple times. It's they're given a further information sheet later on in the pregnancy. They don't have the research staff approaching them. We are very much reliant on women self-referring to us, actually, other than the women in inpatient areas, and we will go and see those women once, and if they don't want to take part in the study, then we will mark them as declined. If they want more time to consider the study, we will go back and speak to them. It's just really making sure with a really small team that we can offer equity of access, really. So it's about making sure there's lots of time points that the information is out there for women to access if they wish to do so. It's not a lot of those time points aren't even having a conversation. Some of them are, but some of them might be a sentence to say, here's an information sheet. So I don't feel that women are being coerced into it. We have 50% of our women that say no and they don't want to participate, and that's fine. And everyone knows it's completely optional. It doesn't affect their care in any way. So in fact, I feel like we have the opposite, women that are contacting us afterwards wanting to be included that were never approached. And that's actually what we need to get better at, making sure that all women do have the option to participate if they wish to do so.
Great, thanks for that, Phern. If no one else wants to come in on that, I'm going to go to another question for you. This one's from Francesca Borzano, who says, midwives across the country are very stretched and issues in maternity wards are fairly frequent topic for newspapers. Is your part of the project aiming to identify how much additional staff you would need to deliver this the work that the project's being done once it stops being a research project and that funding disappears?
I think Amanda's probably best placed to describe what's going to be what's been evaluated as part of the study, but I can answer with regard to capacity for midwives. I think midwives are very stretched. We all know that, and actually, as per my presentation, that's what I said, midwives are already doing this. So they are already taking all the cord blood samples. It's the clinical midwives that take the cord blood samples because it takes a second. They have to look at the placenta anyway. They have to check that it's complete. They have to look at the vessels in the placenta. They take bloods clinically from the cord anyway. Sometimes it's a really quick process. I think what is the time-consuming process is the research aspect of it, which is what we are doing. But women, midwives are already having conversations with women about screening tests. Our community midwives are introducing the study for us at 16 weeks because that's when they said that that's the time point that they can do that and they have capacity to do that then. It's not an in-depth conversation, and it will, if this was ever became part of a screening process in the future, those are obviously things that would need to be assessed.
And Amanda?
Yes, Yes, that is a big question that it forms part of our evaluation of the study, impact on NHS services and what the potential resource then requirements could be. So I mentioned one of my slides on evaluation. I mentioned that there's a group based in University College London that has a multi-pronged project. Their protocol, actually, a preprint is available online. Celine Lewis and Melanie Hill are the joint PIs for that work. And that includes not just asking questions and using that genomic and health data to understand the longer term impacts and outcomes for participants and babies, including those that have had results and those who haven't, but also understanding the NHS staff's experience of being involved in the study and understanding using that their study to help feed information to those decision makers about what kind of resource requirements that might involve.
Okay, another question now, and that's for Amanda, I think. Are the costs and resource requirements of the whole genome sequencing approach being compared to the targeted expanded newborn screening approach used in other countries? This is important to identify for the best screening approach in a resource-limited health service.
Yeah, so there's a couple of ways in which the answer is sort of kind of, and I'll explain why. So other countries obviously have very different setups in terms of not just the assay itself for doing newborn screening, but also what the implementation costs are. So it's going to be very difficult to compare like for like in different countries. But part of the evaluation work I was explaining includes a health economic analysis of the costs of the testing, and they will also be looking at costs of other assays and testing as sort of part of that comparison. It's also difficult, I think, to compare that like for like, because other countries that might be using tandem mass spectrometry, which Robin talked about in his talk, can detect for a wider range of metabolic conditions. Metabolic conditions only make up a proportion of the 200 conditions we're looking for, and potentially the wider subset of other conditions. And not all metabolic conditions can necessarily be found on tandem mass spectrometry. There might be a range of other assays that might be needed as a confirmatory test. So in order to truly, I think, do a like-for-like comparison, you would need another program that was collectively doing the range of all of the other non-genomic tests that might be able to be done to compare to the range of conditions that we're testing for in a newborn sequence. So that like-for-like comparison, I think, would be quite difficult, but I do still think it's really important that we do carefully understand what the costs are, including the downstream confirmatory tests that are done on the back of the results that we provide, including like what Robin was also discussing earlier, cases that we might miss, sensitivity and specificity as part of that sort of wider evaluation.
I shall move on to the next question unless any of the panel want to come in. Nope. Okay, so parents of children who are symptomatic and being investigated for a possible genetic diagnosis are currently waiting many months or even a year or more for the results of whole genome sequencing. Wouldn't it be better to spend the money allocated to the generation study on addressing the backlog in the investigation of these children? Shouldn't they take priority? So perhaps we'll go to Chinthika first with her in her neonatal hat on to go for this one.
That's a really important question. I'm glad someone's asked that question. That's been asked many times by the pediatric specialists that I've been speaking to at our hospital. But I think the generation study is just asking a very different question. And I think the two need to be, I think both need to be addressed, both the screening aspect of it, as well as the how to improve the clinical services for those children who are waiting to have their genetic diagnoses obtained. I'm afraid I'm a very important question, and I hope we can get to an answer better.
I think, Amanda, I'm sure you've been asked this question many times.
Yes, for sure. And I've worked as a genetic counselor in the NHS for many years. I'm really aware of the huge pressures on NHS staff delivering sort of genomic testing services. Absolutely. And actually, the largest part of activity that Genomics England does at the moment is supporting the NHS in whole genome sequencing for diagnostic purposes. And and continuing to hopefully improve how we can make that better. That and the generation study come from very different funding sources. One is healthcare, one is research. I agree with Chinthika that I don't think this is an either or scenario. I think the experiences of families undergoing diagnostic testing is extremely important. And the generation study hopes to be able to address a part of that in some way. It's not going to cover all of the same journeys, but we hope that we can, if we can see the benefits of this study, that should in the longer term help improve the experiences of families going through that situation now, whilst not necessarily needing to take an eye off the experiences that families going through a diagnosis now are having and what we can do to improve it. I don't think it's an either or scenario.
Anybody else want to come in on that one?
Yeah, I mean, the sticking point isn't getting the genomes done. That's a machine does that for you. It's the interpretation. And looking after patients, yeah, it takes months and months to get the results back. And then the problem is, even if you get back a negative and you're convinced they've got the disease, it's not definitive, the genetic result you get back. If you're convinced, you need to go back and say, can you look harder? And it always turns out they can look harder. So it can take, even if you get your first result, it can take a long time for any individual affected patient to work out what's going on. If this was suddenly part of our newborn screening program and we were doing 800,000 genomes a year as part of newborn screening, there would have to be some automated way of doing that. There's no way we would have enough clinical scientists to cover that.
And then moving on, there's been a couple of questions which I think perhaps put to Amanda in the first instance, and they revolve around are variants associated with adult onset diseases like breast cancer, reported them in a couple on that sort of theme. So if you could just sort of clarify what is and isn't be looking for again, I think that'd be helpful.
Sure. So no, adult onset conditions like I think BRCA1 and 2 genes were mentioned in the chat are not being sought in the generation study. Again, we took quite a deliberative and kind of consensus process to try and come up with the 4 principles that define the conditions we would look for, appreciating that any set of criteria was always going to have some gray areas because rare diseases don't always fit into neat boxes. But we really heard strongly that parents receiving results from the study, because again, this is a largely well population, want some certainty and action that could be taken quite early on in life. And that meant that we would focus on conditions that had some intervention early in childhood and avoiding those conditions that could be onset later on in life. One of the kind of ongoing opportunities for engagement that we hope to continue with a public standing group that we have at the moment is at this stage considering what might future uses of a genome look like over a child's lifetime. And that could include at some stage in the future doing different types of analyses. But I think before we did any of that, we'd really need to understand what the views and appetite from the public might be for that, the potential for the NHS at any point in the future, and then increasingly what the views of the actual participants would be before we did anything else.
Great. And then I'm going to get one final question. We've just about got time from David Curtis, and he's asked many questions this evening. So very grateful for his participation and from others who've posted multiple times. And I'm sorry I've not got through them all. But David says, Genomics England always presents the benefit of genetic diagnoses for babies with disease. I fully appreciate this, but surely presenting these stories confounds the issue of benefit or lack of it for sequencing perfectly healthy babies. And I think it's sort of point he's made in different questions and comments about, we're looking at, most people aren't going to, in some ways, directly benefit from this.
That's true of any screening program at the end of the day. I mean, so if you screen people, the majority, the difference here, I think, is that you've taken a genome off them and you're using that for something else. But this is a research study and they've consented to that as part of the research study. In any screening program, you are going to have the majority of negatives, and that's fine. The blood spot test is the test that every baby has and nobody ever expects to get the answer for. What other test would your baby have that you wouldn't be chasing your GP for the answer? Nobody ever expects to do it. So they expect it to be negative, same for fit screening and things. I think the difference here is as part of the research study, you are taking a genome for other uses as well.
Yeah. Yeah, and I think that's why I think it's really important that in describing the research study, and hopefully Phern, you and your team are also feeling this on the ground, that this isn't a purely a newborn screening research study. We are looking at the potential of genome sequencing in newborns. Screening for rare conditions is obviously an immediate next step, but there is a broader aspect to that. And so we think it's really important that parents incorporate that information in their decision making, because it is research and not clinical care, different to the blood spot program. And it was important then that we had scrutiny by the Health Research Authority, which is there to make sure that any research study is balanced in terms of potential benefits and risks, including how that is conveyed to participants in the materials we use. So we feel that hopefully even for the small proportion of babies where we might have a positive impact, like Robin and Chinthika are saying for other screening studies, that could be the huge benefit. But we also, I think, have done quite a thorough job in conveying all the intricacies and uncertainties of taking part in this study as well.
Great. And even when parents consent to their babies having genetic testing for diagnosis, they also consent, many of them consent for the National Genomic Research Library as well.